Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
All right, hi everybody. I'm Becca Hart, one of the attendings in the Peds ED, and this is going to be one of our Louisville lecture series and resident modules for the Peds ED rotation. This is going to be about neonatal emergencies, and there's a lot to cover when we talk about neonatal emergencies. So this might be just one of a few different topics that we cover, and we're going to start with kind of some of the basics. So things that you might expect to see commonly in the pediatric ED, whether or not they are emergencies in neonates. And then we'll get into a little bit more about specific emergency conditions that are common presentations in the neonatal period. So just going through the basics. So newborn babies, the first thing we always tell everybody, and if you're in general pediatrics, you're going to know this. Babies are not just little adults. There are lots of physiologic changes that newborns undergo in the first few minutes and hours after birth. So for example, babies in utero have extremely high right ventricular pressures because they're not breathing air in and out. Their lungs are full of fluid. And so as soon as they're born, a lot of that fluid is squeezed out during the delivery process. They have a drop in pulmonary pressures and increased circulation. They start to close their PDAs, typically within hours to days of birth. And their vital signs are very different compared to older children. And we know that vitals change throughout the period of life. But in a neonate, you should expect heart rates to be anywhere from the 120s to 180s. Less than 100, of course, is abnormal in any neonate. Their respiratory rates are also going to be higher than you would typically see later on. Even up to 50 or 60 can be normal in a newborn baby, as long as they are not working hard to breathe, retracting, and really struggling. We are not going to go into like neonatal resuscitation in this topic or this module because that is a little bit outside of our scope. But remember that if all else fails and you're in the ED and you need to take care of a baby that was maybe born at home or, have just very shortly after birth, if you don't remember anything else, suction, warm, dry, and stimulate. Like just start warming that baby up, stimulating them. And that's going to be the first step in any kind of management. So when we talk about things that babies present to the ED with, one of the most frequent complaints are not always necessarily the most concerning because lots of times new parents are bringing their babies in for things that we wouldn't necessarily consider an emergency. But as I always tell folks, babies do weird things and it can freak parents out, especially if they're brand new parents. And so these are probably some of the most frequent complaints that you'll see in the ED in babies under a month or two old. So especially things like jaundice, breathing issues, whether or not that's actually true difficulty breathing, feeding concerns, concerns that the baby is fussy or irritable, and we'll talk about that word irritable here in just a minute. Concerns about their bowel movements and whether they're pooping normally, and what the parents would call lethargy, so kind of the opposite of irritability, so sleepiness, or are they active appropriately or sleeping too much? As far as diagnoses or workups that we're going to be doing in the ED in this age group, you're going to see a whole lot of normal babies. So folks who come in concerned about something that's going on and everything is actually just fine. We take care of a lot of jaundice. We do deal with a lot of feeding issues. And then the last kind of couple of combinations are babies who need what we call like a rule out sepsis workup. So febrile neonates, for example, or babies who are having trouble feeding and dealing with like dehydration. By far and away, probably the most common four are things like the fussy infant, the baby's crying. Why is the baby crying? Jaundice, conjunctivitis, or eye concerns, and then like feeding and or pooping problems. So we're going to start with a case. You're working in the ED when a mom brings in her 3-week-old infant because she just can't seem to get him to stop crying. He was born at 37 weeks. He has no known problems. Pregnancy and delivery were unremarkable. Mom's history is negative. He's feeding well, he's gaining weight, he's appropriate with parents, he's waking up to feed every few hours just like he should. He has not had any fever, cough, trouble breathing, no vomiting other than the occasional spit ups, diarrhea, no rashes, and he's peeing fine. On exam, he looks very well. He is sleeping comfortably in mom's arms. He wakes appropriately when you stimulate him, but nothing really focal that you can see. On further history, mom tells you that he always seems fine in the morning, but then in the afternoons and evenings, he just starts to cry and cry and cry and is often very difficult to console. A lot of times they will just put him in the car and drive around for a few hours, and that literally is the only thing that will calm him down. So When we think about the fussy or crying infant, again, this is a very common reason why parents come to the ED with their child. One of my favorite mnemonics that I refer to over and over again in the ED is "it cries," which you can literally Google anytime. Just say "it cries mnemonic" or "fussy baby mnemonic," and you'll probably find this one right away. So the I stands for infections. So in a fussy infant, you do have to think about infectious processes like whether it's a UTI, meningitis, or sepsis. T is for trauma. So that could be fractures or injuries. That could be shaken, head trauma from shaking. That could be hair tourniquets, things like that. C is for cardiac. So a fussy baby that is very tachycardic may be an SVT and maybe crying because they're uncomfortable. C can also stand for colic, and that one's a tricky one that we'll talk about more in a minute. R stands for reflux, for rectal or anal fissures, and for reactions to medications. The second I is for intussusception, although much less likely in the direct neonatal period, more likely once you get into like that 3 to 4 month mark. E is for eyes, so like a corneal abrasion or a foreign body. And then S is for strangulations or surgical processes. So that's things like hernias, torsions, a volvulus. Some people will also consider tourniquets in this part of the mnemonic. So when you have a fussy baby, the first key thing to do is always make sure you do a really thorough head to toe exam. So you're thinking about all these things and thinking about that "it cries" mnemonic and going through, okay, do they have an anterior fontanelle that's nice and flat? Or am I worried about meningitis? Do they have any bruising? Do they have any signs of trauma? Do they have, any deformities of their extremities? Or are they moving them well? Looking at things like their mental status, looking and see if their eyes are red, or even doing a fluorescein exam to rule out a corneal abrasion, making sure that they have good pulses, good heart rate, and that they're circulating appropriately, making sure that you do not see any masses on their abdominal exam. Of course, it is very difficult to assess for like rebound and guarding in a neonate, but you can still feel for those masses or for like hepatosplenomegaly. Make sure you do a good GU exam, assessing for like a paraphimosis in a circumcised male, assessing for, or I'm sorry, for in an uncircumcised male, assessing for hair tourniquets on fingers, toes, penis, clitoris, making sure that you don't see any hernias, particularly in males, but also in females. And then also making sure that there's no like perianal or rectal fissures. Looking at the extremities, again, for hair tourniquets, but also making sure that they're moving the extremities and there's no deformities to suggest fractures. And of course, a thorough skin exam to look for cellulitis, for any like petechiae or purpura or bruising that might occur. And as I mentioned, that second C in the mnemonic stands for colic. So it's one of those things that can be really a diagnosis of exclusion. So once you've done this thorough exam and you've really ruled out all these other things, colic kind of becomes a little bit higher on the list. And the classic mnemonic for colic is the 3 Cs. So 3 hours of crying more than 3 days a week for more than 3 weeks in an otherwise healthy infant. Generally speaking, there is no clear organic cause for this crying, so you've ruled out all the other things. And it's really that classic like witching hour kind of presentation. Like most families will tell you the baby is crying mostly in the afternoon or the evening. This does typically peak is kind of at its worst around 6 weeks and usually improves by about age 3 months. But it's just really frustrating to parents. And so when you're in the ED dealing with a family who's at their wits' end with a crying baby, one of the most important things, in addition to ruling out other medical causes for the fussiness, is to make sure that you're just counseling them on safety, letting them know that, like, this is normal, it is horrible, it's very frustrating, and it will get better. But right now, they're in the thick of it. And so making sure that they know that if they need to put the baby down and walk away, that's okay. Make sure the baby has a safe space, but it's better for them to be crying than for them to accidentally get shaken. I generally counsel them that changing formulas is unlikely to fix colic. They are certainly welcome to explore that with their pediatrician. But in the ED, unless there's a really good medical reason, I typically don't tell them to try to change formulas and see if that helps. Hair tourniquets, we mentioned, another really common cause of fussiness, and on our "it cries" mnemonic, they are most commonly found on the fingers and toes, although they can be seen on the penis or the clitoris in females. And you'll typically see this like little sort of indentation all the way around the finger or toe with it being very red and swollen. So making sure that you're looking for those is important. There's lots of ways to remove hair tourniquets. You can, if you can find the end of them, you can unwind them with forceps. If they are not synthetic, like if it's a human hair and you can tell it's a human hair, you can try Nair, which we do keep in the ED. If they're truly deeply embedded, you can also use incision, where if you can get a blunt probe underneath them, you can cut them with a scalpel. And if you can't, you can actually literally cut all the way to the bone. So you try to numb up the finger or toe the best you can. And it's literally just basically a slice into the skin on both sides to free that hair up. It's often difficult to know unless you literally physically pull the hair off yourself, whether you got these all the way off, because the swelling's not going to go away immediately. So I always also make sure to counsel the families really well that this is something that they should follow up very closely. If it's not getting better, they should come back to the ED, or certainly see their pediatrician within the next day. Corneal abrasions, also a very common cause of fussiness. If babies, babies have very sharp fingernails as a rule that are very difficult to trim, and they have very little control over their hands. So they scratch and swipe and things like that without meaning to. You can diagnose these using a fluorescein exam, which is what's shown here in this picture. What you're looking for is like a streak or a line or a circle that's taking up more of the dye than the rest of the eye, just like this one. You can see that very highlighted sort of linear like squiggle on the eye, on the actual surface of the cornea. As a rule, these don't take a lot of treatment. They will get better on their own, but they do hurt. Erythromycin ointment is our go-to, not only because it will help prevent secondary infection, but is very soothing, and will help with pain. Moving on from fussy infants, jaundice is also a very common presenting symptom to the ED. So especially in those first few days of life, a lot of babies, are screened when they leave the hospital and then screened again at their pediatrician if they have elevated levels or are high risk. And so if they do get higher at that ED or at that PMD visit, they will often end up in the ED. Of course, we hopefully remember from medical school that jaundice is a result of the breakdown of hemoglobin into bilirubin. So it can either be caused by too much hemolysis, breaking down too much blood, by failing to conjugate the bilirubin in the liver, or by failing to excrete enough of the bilirubin. Knowing whether the jaundice and the elevated bilirubin is direct or indirect, conjugated or unconjugated, is very, very important. And so our first assessment is generally to obtain a fractionated bilirubin level. If the bilirubin is highly unconjugated or indirect, then commonly this is just physiologic. Lots of babies have jaundice. They're not really sort of ramping up all the enzymes to process that bilirubin yet. You'll also hear us talk about breast milk or breastfeeding jaundice, which is common in breastfed babies. You can see elevated indirect bilirubin, though, from hemolysis. So asking thorough history questions or looking at the newborn record is very helpful. It's looking at whether there's an ABO incompatibility, so mom's blood type, baby's blood type, finding out if the baby had a cephalohematoma because they might be breaking down extra blood from all of that blood that was kind of stuck in their scalp from when they were born. And then, of course, asking about other family history of like blood dyscrasias, like sickle cell disease or G6PD, that would cause them to be turning over more of their red blood cells than typical. And then last is sort of those like diagnoses of exclusion, again, like Gilbert's syndrome or Crigler-Najjar, which are generally less common in this age group. If the bilirubin is mostly conjugated, this is generally much more concerning. Conjugated bilirubinemia is generally pathologic until proven otherwise. And the number one thing you have to worry about is biliary atresia. So identifying a conjugated bilirubin or an elevated conjugated bilirubin level should immediately trigger a few different things. Number one, you're definitely going to need to get a right upper quadrant ultrasound and make sure that you can actually see that there's a gallbladder and a normal formation of the biliary ducts. Because if there's not, the earlier that we can diagnose biliary atresia and get that baby to surgical correction, the better the outcomes will end up being. You also have to consider the possibility of torch infections or sepsis in babies with significant direct bilirubinemia, and so a sepsis workup is often necessary, as well as things like metabolic disorders like hypothyroidism or galactosemia. Remember that jaundice in the first 24 hours of life is always pathologic. It's never going to be physiologic or breastfeeding or breast milk jaundice. If it's in the first 24 hours, it deserves workup. Beyond that, you're going to go back to these ideas and check that whether it's unconjugated or conjugated first. So make sure that you get a good, careful history and exam to help determine possible etiologies. Things like when did it start? How's the baby feeding? What color are their stools and urine? If they are, having very pale stools or very dark urine, then that may raise some suspicion. Again, looking through the chart or asking the moms if they know the baby's blood type and their blood type. Obviously doing an exam and taking a look at the baby. Do they look well? Do they look sick? Do they look potentially septic? Do they have a big cephalohematoma, or are they covered in a rash that might suggest a torch infection? Will all help you while you're waiting on labs to come back. So once you've got your fractionated Billy, your next step is going to be to take a look at the nomogram. If that Billy is mostly unconjugated, then really all you have to kind of do at that point is make sure that you know whether the baby needs either phototherapy or exchange transfusion. If it is mostly conjugated, you're going to get a whole lot more workup, particularly looking at things like a CBC, CMP, urine, cultures, and potentially LP if you're worried about sepsis. And then maybe type and screen or a Coombs if you have a lot of concern for the potential for hemolysis, or if their hemoglobin is low overall. So this is our bilirubin nomogram. Hopefully everyone's seen this before, but this is how you're going to figure out where they lie as far as needing phototherapy. There is a separate nomogram that will help you determine if a baby needs an exchange transfusion. And you can see that the age of the baby is down at the bottom of the nomogram, and you have 3 different lines for risk categories. So infants at low risk, which is the highest line, the dotted line, are those who were born more than 38 weeks and who are well appearing. The dashed line in the middle is for those at medium risk, so either babies who were born at 38 weeks with risk factors like an ABO incompatibility or a family history of G6PD, or babies who were in that late preterm age, 35 to 37 weeks, who are well. And then your highest risk category is the solid line at the bottom, and that would be your babies who are born early with risk factors. You can also find essentially the same results as the nomogram by using online calculators like Billy Tool. Those are perfectly reasonable and fine to use. But if all else fails, you can always go back to this. Couple more things and then I'll wrap up for this particular session. So conjunctivitis is again a common presentation in the neonatal period and can be either really not serious or very serious depending on the timing and the presentation. So the first thing you want to know if you see a baby who looks like they have conjunctivitis is when did it start? So if it started or occurs in that first day of life, if you're rotating in the newborn nursery or you have a home birth baby that comes in with conjunctivitis, that is typically chemical conjunctivitis from like the vitamin, or I'm sorry, not the vitamin K, the erythromycin ointment that they get in the nursery. Babies born and who develop conjunctivitis within the first 2 to 5 days of life, that is more likely to be gonorrhea, which is very serious and prompts a septic workup. Gonorrheal conjunctivitis is also typically much worse looking. So those eyes are gross. You open them and pus just pours out. They're typically markedly inflamed, very red. You're not going to miss a gonococcal conjunctivitis. By contrast, chlamydial conjunctivitis usually comes later, so in the 2nd week of life, and is typically more mild. One way you can tell the difference very quickly and easily is just by getting a gram stain of any fluid and looking for bacteria. So if there's no bacteria and everything is just clear, it's probably just chemical conjunctivitis if it's early, or maybe even a clogged tear duct that's just looking like conjunctivitis. If there are obviously like diplococci, you know it's gonorrhea, move forward with a workup. If there are lots and lots of whites but no bacteria, then you're going to be thinking about chlamydia, because remember that chlamydia is an intracellular organism and not something that you will see on a gram stain. Also, please remember that the topical prophylaxis that they get in the newborn nursery, the erythromycin ointment, only prevents gonococcal infection and not chlamydial infection. So for chlamydia, if it is that, you do have to treat it parenterally with erythromycin, not just topically. And then, of course, gonorrhea, you would treat, you would do a full sepsis workup, as I mentioned, because it's much more likely to spread, and also will require treatment with like Rocephin. Finally, we'll wrap up with some common things that parents come in with that are generally not actual problems. So, feeding and stooling concerns. Lots and lots of parents come to the ED with concerns or questions about how their baby's feeding, how they're peeing, how they're pooping. Um, Newborns, as a rule, feed on demand. There is no such thing as feeding them too much or too often. So a lot of times they will cluster feed, especially when they're first born or with any growth spurts. Those first few days, they may take less than an ounce at a time. By 1 month, typically 2 to 4 ounces every 2 to 4 hours is about normal, but lots of parents overfeed babies because they assume that anytime the baby's crying, that they want to feed, or because the baby, if you put something in a baby's mouth, they will suck on it. It's a reflex. And so if a bottle's in the mouth, they will suck and they will drink it, which is often leads to parents assuming that, oh, well, they're still hungry. So if you have a parent that comes in with like a fussy baby who is getting fed 8 ounces at a time at a month of life, it might be because they're getting a little overfull, having some reflux. Um, when it comes to stooling, tons and tons of parents bring their babies into the ED for concerns about constipation in particular. They worry about constipation because the baby maybe didn't poop that day or is straining when they try to poop, turning red in the face, that kind of thing. As a general rule, if the baby is still pooping soft, like if it's still pasty or soft when it's coming out, they are not constipated. Lots of times babies will go a day or even a few days without stooling, and that's totally normal as long as what's coming out isn't like hard rabbit pellets. So I use what I call the rule of sevens. So babies can poop every 7 days or 7 times a day. That is all okay. If they're going more than a week without it, or if it's coming out very hard and rock-like, that is typically when I will start investigating for actual constipation. So I will catch up with you guys on another round with our case 2 and some ongoing ED neonatal complaints. Please reach out if you have any questions about this lecture, and I hope that it was helpful, and have a great rest of your rotation with us. Thanks, guys.